All right. So is everybody ready here for another lecture? Is that me here making that noise? Okay. Well, my name is Garrett Sullivan. I just want to thank the organizers here today and have invited me to speak to you guys. Again, I'm from the University of Kansas Medical Center. I work with the Integrative Medicine program there. The unique thing about my practice with my partner, Jeannie Driscoll, is that we both got pulled into this whole world by Hugh Riordan, and I think that's pretty special. I met him in the summer of 2004, and then he died the January of 2005. But by that point, he had pulled me in, and I could never turn back. So here I am in the IV vitamin C world and firmly embedded in the orthomolecular medicine model. So I was asked to present some of our data as we get into clinical trials. Again, as you guys may know, if you're giving IV vitamin C, the traditional oncologists get a little bit nervous sometimes about us introducing the IV vitamin C, especially if they're trying to facilitate anti-cancer effect with their chemotherapy. Anyway, they always want these trials to be able to support what they do. So this is just a step towards that goal. Okay, so now really quick, I know Dr. Ron's father died last night, and it's a, I think he did mention that, did he not? But anyway, okay. So I hope I wasn't letting the cat out of the bag. But we switched our presentations around. So we're going to see some of the same things, and some of the same points will be reiterated, but there's a little bit different slant on the data from this presentation compared to his. And you'll kind of see where some of these differences come up. So I want to go back all the way to the beginning here and start with Albert Szent-Györgyi. He's one of my heroes in medicine and science, just generally speaking. But he's the one that actually won the Nobel Prize for the discovery of vitamin C. Actually, what he was working on was this combustion process, the process by which the body will burn oxygen, just like a fire would, just to maintain its energetic metabolism, so to speak. So he actually followed this burning or this oxidative process or this burning of the electron energy that is available in these, namely to create this combustion process. And actually, by doing so, he became the father of bioelectronics as he was following the electrons around. But what he really pointed out was that to be a living system, you have this excitation, de-excitation dynamic always at play within your molecules. Now, you might not ever stop to consider where the energy comes from, but our molecules are actually charged with energy that gives us buoyancy so that we actually have some energy to withstand the environment, withstand gravity, and we're not in the ground state whatsoever. We actually are above the ground state, and by doing so, we've absorbed energy into our structure to create this excitation dynamic. Now, if you guys have never stopped to think about this, this is where some of the quantum mechanics ideas come into play. And medicine is one of the last sciences that has yet to fully embrace this quantum mechanics that has become recognized as the most fundamental way to describe reality and nature. So I just want to point out here that when you're in the ground state, this is just inanimate material. And if you absorb photon energy or light energy, you actually raise yourself above the ground state into these excited states of existence. So you get these atomic transitions, and these are very discrete transitions that each molecule can attain. But anyway, as you go from one state to the other, if you're going up from a lower energy state to the higher energy state, you're absorbing photons. As you go from a higher energy state to a lower energy state, you're emitting photons. And when you stop to think about the Michaelis-Menten enzyme reaction models, all you need is a little bit of energy to get over the hump so that you can run your metabolic pathway. And it's these photons that are believed to create or to provide this energy for our general metabolism. So another wonderful thing about Albert Szent-Györgyi was that his whole focus became that of water and the matrix that this provides for the stability of the living system. Now this brings up some interesting points, and there's some interesting observations all throughout this. But we as humans are about 70 to 80% pure water, and so we have we carry our water with us. Now this is interesting, and I just want to point out that water inside a living system is pretty special water, and I think it comes to the forefront most when you consider jellyfish. I don't know if many of you have played around with jellyfish, but some species are 99.9% pure water, which is incredible because the ocean is only 97% pure. So that means the jellyfish are more pure water than the water that they live in. So it's a pretty phenomenal structure. Okay, hold on a second. So anyway, what is the implication that we actually have energy in our matter? And in essence, we've got light in our essence, which gives us that buoyancy, or that, again, that turgor that we can lift up against gravity and be able to fight off the environment, so to speak. Now this is interesting in the sense that this came out of the work of the International Institute for Biophysics and Fritz Albert Popp's work, if you've ever read some of his stuff. But he showed, like, if you have a collection of normal cells, this axis shows the total cell counts of light emissions. And you can actually measure the light emissions coming out of biological material, and these are called biophotons. And, but as the tissue grows, like as a baby would grow, you actually hold on to the light better, and you actually can strengthen yourself by holding on to that and preserving that better and better as you get more cells involved in that organism. Now, compare that to the cancer cells. As you get a bigger and bigger mass of cancer cells, you can't hold on to the light, and the light just starts to flood out. Now, this is a serious leak because there's no way for the individual to hold on to that energy that will give them that, again, that buoyancy so they can maintain their vitality and their viability. So I want to go back now a little bit. Again, this kind of correlates with what Dr. Ron mentioned. But this is going back to the 20s now. Erwin Bauer was a Hungarian biologist, and he developed these postulates of living systems. I want you to, this is actually incorrect right here. This is supposed to be the principle of stable non-equilibrium. Just like Dr. Ron was saying, we have these cycles always in flux. You know, you're in the redox environment, so you've got a reduced molecule. It'll oscillate back to the oxidized form and back and forth, back and forth. So I want everybody to change that on your handouts. So this is the principle of stable non-equilibrium. If you do find yourself reaching equilibrium completely, then you've no longer got movement with which to perform work, and that's just not compatible with the living state. So you always have to be in flux, always open to the environment, and always feeding in and out of what's coming into you from the environment. So what provides this stable non-equilibrium? This is that structural energy, again, that light energy that's been absorbed into our material to give us that buoyancy. Now, as we're constantly trying to balance that, we've got this internal work where we'll fluctuate between the reduced and the oxidized state. But ultimately, we'll always want to slide to the ground state as we metabolize. Again, water, it was shown, helps to facilitate charge transfer. And that's, again, where the vitamin C came in as well. But as you metabolize, you'll slowly use that stored energy because, again, you're using those photons to drive your reaction processes. So then we get to this external work where you actually now have to go out into the environment, find a way to get more structural energy back into yourself. And so you've got to go out and figure out how you're going to do that. So this is the principle of external work increasing as the historical trend. So the longer we live, the more we're going to have to go out and replete our exhausted structural elements so that, again, we can maintain our viability. So this comes back to the basic process. So you never really thought what it really meant to eat food, and good light-filled food. Namely, you know, we've been talking a lot about the mitochondria and going through the electron transport chain. The whole point of this mitochondria is to extract that light energy right off of the food so that then we can transfer it to a usable form in our bodies. Now, everybody focuses on the ATP, but really the ATP is only a small piece of this. It's that water that actually carries probably the majority of our metabolic energy. And I'll come back to that in a second. But anyway, we've got to start with this living substance. You know, when we go out to get food, we're not going to go out and eat inanimate ground state material. We're going to go out and eat living things that also has that buoyancy or that structural energy a part of it so that we can go out, pluck it off of its living source, eat it, and extract that light energy right out of it so that we can actually make ATP from that. So the goal is to acquire living substance, which is fresh food, it's water basically, with dirt or this elemental material substance such as minerals, essential amino acids, fatty acids, with the sunlight mixed in. So again, we have that energy we're going to extract off the electrons. Again, that's what the electron transport chain is all about. We're going to extract that electron energy right off, convert it over to make ATP, and at the end, deliver those electrons to oxygen, which is the final electron acceptor. So anyway, what does it take to maintain the viable living state? Is that you need energy, and you need that energy to be organized and coherent such that all of the pieces of that living system are working for the good of the whole. So now these are some renditions here of these have different names, but these are zones of organized water, namely. Now when you stop to think about it, I'll just go to this. Water, as Albert St. Georgi elucidated, really does provide the matrix that makes sense of all the other biological material. It really does provide the structure in the material sense as it organizes all other biological material. Now, when you stop to think about it, no other biological material makes sense without recognizing that water is constantly surrounding it. You know, the tertiary structure of all the proteins are fully defined by the hydrophobic-hydrophilic interactions, and so you get the quaternary structures forming based on how the water is directing that folding. All the membrane structure as well, there's a very clear hydrophobic part in the middle of the lipid bilayer. The edges of the membrane are hydrophilic and love the water. So you have this stable membrane that then can help you subdivide the organism and maintain some sense and organization. So this starts to explain some things because when you look at any interface in a biological organism, as people have looked at this, if you have a membrane, they've shown that the water will stay in perfect phase with that membrane a couple 100,000 layers thick. So that's a lot of molecules stacked up one next to each other. So this is, again, a rendition of that. And this was a pretty profound idea. And actually, this was the whole point that the MRI was created, because the idea was that each tissue, each organ, each domain of the individual will have its own unique organization pattern of the water that then defines that particular domain of the individual. So if you see a disruption in that water domain, then you know there's some sort of pathological thing going on in that space. And this also explains how when you peel off like 10% of a cell membrane, the water doesn't even run out. It's actually a gel in there. And actually, Dr. Pauling has elucidated a lot of those dynamics where you can peel off huge sections of the membrane, the water does not run out, and you don't even change the potassium-sodium balance, even though you've taken off a huge chunk of the membrane. So really, this water does provide a source of usable activated electrons, because to maintain that type of connectivity, you've got to have some energy tied up to maintain that binding potential where everything stays in order. Dr. Vladimir Voykov is one of the premier water researchers. He's from Russia. I'd encourage you to read some of his papers. Anyway, now this kind of resets the stage for how, or resets the stage for how we organize cancer grading, for example. Now, as you can see here, these are well-differentiated tumors here, and they look, you know, pretty well put together. Now, as you go down in the aggressiveness of the tumors, they get more and more disorganized, where you're poorly differentiated. And what you're seeing here is just a disorganization of the water, and therefore all the structure breaks down. Now, we are talking about, is it the tumor or is it the environment that the tumor is within? And this is clearly starting to show that it's the actual environment that makes the cancer phenotype emerge. And again, this is how we diagnose cancer, is under the microscope, how disorganized that structure becomes. Again, it's the disorganization of the body water. So what does that mean exactly? So again, in this slide here, you've got this nice organized tissue structure, and actually they've done studies too, you can measure the squishiness of a cell, and that will actually define how aggressive that tumor is. So if you've got a really firm cell, it's not going to be as aggressive as if you squeeze it and it's just all disorganized and squishy and not very well organized at all. Just like if you were a woman that had a breast lump, you'd much rather have a discrete, firm nodule than one that was just mushy and ill-defined, and it would probably imply that that was a lot more aggressive tumor. So anyway, you do see this shift from an organized collection of cells all working together, where you kind of resort to this more primitive style of existence, where you kind of revert to a more prokaryotic type of existence. Now, there's a lot of epithelial markers that correlate with this type of setup. There's a lot of mesenchymal markers that correlate with this type of setup, and we've actually started to look at this with the IV vitamin C as well. So now, how does the cell become squishy? You've actually disorganized the water. So what does that really mean? Now again, the water is really what the final is the final electron acceptor of the electron transport chain. And if you can't get the energy to those electrons, then your redox shift will decrease. Now we're coming back to this redox medicine, which is very confusing, and if you're having a hard time following the first lecture, you're not alone. This is a very difficult concept, and it all depends on what your frame of reference is. Because when you're talking about one thing being reduced, another thing's being oxidized, it starts to become a little bit difficult to keep straight. But anyway, what this is showing, you can't see this line very well, but a normal cell here will oscillate kind of in a like a sine wave kind of thing, where the redox potential will rise and fall, rise and fall. And when it gets, the redox potential gets the highest, the cell will go into the cell halt stage where it won't replicate. Now, if you get into a cancer cell, you've lost the ability to regulate that redox potential because you're shifting away from the mitochondrial electron transport chain. Okay, so anyway, in this case, the redox potential is even a little bit higher than the baseline normal cell, but you lose this oscillation ability just because you can't create reactive oxygen species if you're not using your mitochondria. So this is there's some bunches of papers about this ramifications of a redox switch within a normal cell and its absence in a cancer cell and how this controls the cell cycle. And now I need to just touch on, okay, let's try to explain this in the most simple ways possible. Now, redox potential is in regards to this oxidation reduction or reduction oxidation potential. Now, I think the easiest way to think about this is just to keep in mind, again, we're following the electrons around. Electrons, just by convention, are labeled a -1 charge, and they're always balancing the protons, which are a +1 charge. So the more electrons you have, in essence, the more -1 charges you have, and the more reduced you are. So actually, this is a great thing, and when it comes down to it, we all essentially like to live in the reduced state because it just tells us that we've got energy at our disposal to play with, and we can neutralize and interact with the environment appropriately with. So if we have those reducing capacity, we actually have electrons at our disposal, and the only way to get electrons tied into the structure is, again, through the electron transport chain as we steal them off of the food that we eat. So anyway, so this is what it comes down to. Again, this is a rendition of the electron transport, or the mitochondria here. And basically, this is our central energy pathway. Essentially, all the foods that we eat have to get pulled into this cycle, the citric acid cycle, run through the electron transport chain here. And again, the final electron acceptor is oxygen, and it converts it back to water. Now, this is our only pathway to get back into the energized, activated water pool. Otherwise, there's no way to get back into it. Now, again, the star here has ATP in the middle, and again, that's what everybody's focus is, but I don't think that's the major role of the mitochondria. ATP actually only accounts for 40% of the electron energy that runs through the mitochondria, which is pretty interesting when you crunch the numbers. Now, this is another interesting point, is if you just want to run one proton pump in the surface of a cell, you know, with the sodium-potassium pump, for example, if you just crunch the numbers for one, and you know the potential difference that you've got to fight against, and you know how much you're feeding that cell, already you've got about 400 times too little energy to run even one proton pump. So there's something wrong with the picture, and we're missing a lot of energy because we know there's hundreds of these pumps in each surface of each membrane. So in my opinion, as well as a lot of other people who have been looking at this, the true purpose of this mitochondria may simply be to activate our oxygen and then hence refill our water domains with energy such that we can maintain our structural and energy and organization. So this does provide a path for excited state pool of structural energy able to perform work, and it provides a path to attain coherence amongst the whole system. Now, again, showing that picture where the light starts to flow out of the individual, this is just a rendition of all the structural elements, again, falling to the ground state, those photons coming out, and the body can't hold on to them. So in this case, we mentioned the Warburg Effect, Otto Warburg. He in the 20s won a Nobel Prize for this, but virtually all cancer cells will have a degree of this Warburg Effect where even if you have oxygen around, you'll still choose to burn it by the lactate pathway, which bypasses the mitochondria altogether. So now if you go the main way through the mitochondria, you get about 32 to 36 ATP per molecule of glucose. If you go the lactate way, you only get 2 to 6. So the body's like, you know, it needs the energy, so it clearly recognizes there's a leak here, and the organization of that center is going to slowly dissipate. You'll get more and more hypoxic in that area, again, because we're just burning up the oxygen just like a fire would. So anyway, this is a rendition of the electron transport chain just as the oxygen flows through. So you've got oxygen coming through, it becomes superoxide, it becomes hydrogen peroxide, the hydroxyl, and then back to water. Again, picking up a little energy every time a new reactive oxygen species is made. So again, if you're bypassing this process, you've got no way to mount an oxidative burst mechanism, and in essence, then you can no longer run your apoptosis pathways. And you've got a defective activation of water pathways, you can never regain your organization. So anyway, this cancer cell metabolic shift simply is a disrupted restorative pathway for reactivation of your body water. With metabolism, your pool of energized structural water will slide to the ground state. Coherence and structural integrity will dissipate. And this is, again, how the cancer phenotypes begin to emerge. So again, I want to come back to this central energy pathway real quick because, again, this is classic orthomolecular medicine. Because, again, this is kind of a lot of busyness, but there's little cofactors driving each little reaction wherever there's an arrow. So like just between here, we've got glutathione, iron, and a cysteine group. Here we've got a bunch of B vitamins, the first step of B vitamins, lipoic acid, you know, all these little players. So if a person can't run this very well, now we've got some leverage points to try to grease that up for the person. And this is where our nutritional profiling can come into play. So this is a pretty classic cancer nutritional profile. I like this one because it just brings up so many awesome points. On one side, you've got folic acid and B12 excess typically. You get an electrolyte imbalance, potassium will often fall. The elevated copper to zinc ratio starts to increase. Copper is actually a cofactor required for essentially every one of the pro-inflammatory cytokines. Zinc is one of the most robust anti-inflammatory molecules in our body. Interestingly, if this iodine starts to become elevated. Now this is an interesting observation, but iodine seems to provide a placeholder in the extracellular space. And if you break down your body water, the iodine won't stay in the matrix and it'll start to become mobilized, and we see this often going up, and we can use that as a prognostic indicator. Because the higher the iodine goes, the worse their body water seems to be, and the more likely they are to not survive because of their lack of organization. Homocysteine also starts to go up. It's a stress marker. I'll explain kind of the implications of some of these markers in a moment. You'll often start to see excess B2. In this case, they're way over the top at 40. The reference range is usually 3 to 15. And then you start to drop out the B6 and the selenium. And ultimately, this is great because we measured the CoQ10 levels. And again, this is one of the cogs of the electron transport chain. But you can actually see, or at our university, they actually gave you a measure of the reduced to the oxidized ratio. So in this case, they're 80%, or excuse me, 87% reduced, meaning they're 13% oxidized. Now typically the reference range for this is about 92 to 98%. So if you start to, so in essence we're all in the reduced state, again carrying electron density and electron energy. And as we lose that, we become more oxidized, essentially because we've lost our reducing capacity because we don't have electrons at our disposal with which to meet the environment anymore. And so now we're just getting slowly taken advantage of by the environment because we don't have any ammunition or these electrons to go out and meet the environment. Okay, so this is again what Dr. Ron was talking about as a signal that says, hey, we've got a problem here. You get into this oxidative stress. And I love this figure because if anybody comes to my clinic and has a problem of any kind whatsoever, you can usually see the disturbance with the pieces on this profile. This oxidative stress is a signal that says, hey, we've got a little work to do. And you can see this cycle gets turned off, which is the methylation cycle. And when you review your biochemistry textbooks, this methylation cycle drives all of the parasympathetic nervous system activities. So all the rebuilding and regrouping, rest and relaxation mode types of things. Now, when you've got some work to do, again, this gets upregulated here. Again, this cycle is regulated by B12 and folic acid predominantly. This is regulated predominantly by B6 in multiple steps along the way. So the point is to try to get to this reduced glutathione spot, which is, again, a pretty robust antioxidant. But anyway, a phase 2 detoxifying enzyme allows you to process things and get them back out of your body so that you're not going to get hindered by it. Now, so this bottom half, this is kind of when you get triggered by the fight or flight response. You've got some work to do. And this bottom half is all about processing, getting rid of whatever that environmental stressor is. Once you've gotten away from whatever that thing is, then you can re-engage this wheel again, which is your parasympathetic nervous system, and will help you regroup and rebuild, get a good night's sleep, get some food to start rebuilding your structure and whatnot. So this is by far the most important pathway that I use day in and day out. So anyway, going back to the patients again, we talked a lot about lactate. So this is one of our cancer patients, one of our pancreatic cancer patients. And these are all of it. This is a urinary metabolic profile, and you can see all these little metabolic byproducts. The only abnormality really on this whole page is the lactate is just going off the charts. So this does confirm there is a true metabolic shift in these patients, and they start to metabolize down the anaerobic pathway. So again, if you're going down the anaerobic pathway, you've got no way to reorganize your activated oxygen or water pool, and now you don't have a place to store those electrons with which you can meet the environment. So actually, the body wants that energy, though, so it starts trying to feed it in as fast as it can. So just like Dr. Ron was saying, you can do the measurements with the O2 exchange ratios and whatnot. So we did some metabolic testing in the exercise physiology lab. And just when this gentleman with pancreatic cancer was sitting down doing nothing, he was already burning 24 or almost 25,000 kilocalories per day. Again, this is pretty tough to keep up with for anybody. And interestingly, at rest, he was using all carbohydrates. So again, just using glucose to try to fill that gap, fill that energy leak, so to speak. So if he started working just a little bit, he just walked a little bit, his kilocalorie per day intake jumped up to 5,500 kilocalories per day. And then he just did a little easy run. And at the time, this guy was playing basketball, working out very hard. And they said he said they would only let him run a little bit. And he was already jumping up to 8,900 kilocalories per day. So this is almost impossible for somebody to keep up with. And so no wonder people just start to lose weight like crazy. They just get behind the 8 ball, so to speak, and start to just waste away, so to speak. So these are some of the systemic effects. You get the weight loss, the cachexia, again, which again is a metabolic disturbance that typically can't be overcome with food. It's usually set in the setting of inflammation and oxidative stress, chronically in the fight or flight mode, so you don't even have an appetite to try to regroup and rebuild from, and you just get into this general functional decline. And actually, this has been coined the Oncometabolic Syndrome, and Jeannie Wallace, she's a registered dietitian, has been one to push this idea perhaps more than anybody. But again, we're going to some of these nutritional cancer markers like what Dr. Ron was mentioning. So we've got the C-reactive protein as a marker of that background inflammation. Now I put this in here, but really this should be the high sensitivity C-reactive protein. It's a little bit more specific to the heart and shows a little bit more specificity on how much inflammation truly is there. But anyway, a lot of the studies will use that high sensitivity C-reactive protein. The hemoglobin A1C, how well you're managing your blood glucose. Again, we start to treat our cancer patients almost like diabetic patients because they just start to use their glucose totally abnormally. The zinc to copper to zinc ratio, again, copper is a pro-inflammatory mediator. It runs pretty much all the pro-inflammatory cytokines. So, and actually copper is what drives a lot of the angiogenesis to those tumors. So you want to maintain a copper to zinc ratio of a 1-to-1. As the copper goes up, you can start to predict all-cause mortality as that copper goes up relative to the zinc. And actually, this was pretty interesting, but the first few people I started working with when I saw this huge copper to zinc ratio, a couple of them had cancer. And the first two I saw, they had a 3-to-1 ratio, and they died within a couple of weeks, and I didn't even have time to do anything with them. And I was just like flabbergasted. I was like, oh my gosh. And there's another gentleman who had a 3-to-1 ratio, but he had elevated ceruloplasmin, which actually helped to bind up some of that copper and actually bought him some time. He had lung cancer just all over the place, and sure enough, we were able to support him for a whole full year when he was just given a couple weeks to months to live. The third one was a cystic fibrosis, or the fourth one was a cystic fibrosis woman who also had elevated ceruloplasmin, which again I think allowed her to work through that disturbance of the copper and the zinc. And as we supported that, you know, this works on a teeter-totter, so if you just add zinc, the copper should come down. And actually, we were able to convert that to a 1-to-2 ratio, and she has done phenomenally as far as her overall status has gone as an individual with cystic fibrosis. Anyway, vitamin D also is a nutritional cancer markers. We try to get our levels up above 80 in the patients. Finally, this fibrinogen, keeping that low under 310 is another strong marker. All of these have very strong support in the literature, and if you can meet these targets on all of these, then cancer outcomes are very much consistently improved. Fibrinogen is just a protein that the tumor cells can kind of coat itself with and hide from the immune system. And again, this is the predominant target of like the Wob enzyme therapy that you might hear about from like overseas, which is where it's used more often than here, but the enzyme therapies will try to break that down. So again, if you're running out of energy, now we've got this metabolic profile again, and see these markers of detoxification are all going higher, reflecting that he needs a little help with that. Also, some markers of bacterial metabolism are going up. So again, this person's just kind of getting inundated by the environment and is getting taken over by it, so to speak. And then this gentleman, again, this is a gentleman with pancreatic cancer. He actually was an occupational consultant where he would go out to these sites and try to help them clean it up so it'd be safer for their workers. So he was always getting out into these sites that were just notoriously dirty, so to speak, with all kinds of toxins. And you can see his load of toxins is just off the charts across the board with a lot of these just common things we all come in contact with. Now, interestingly, this benzene, he can hardly excrete at all. And benzene, we know, is a strong carcinogen. And so in this, you know, here's the population ranking. So this is about the mid-range mark of the population. In this case, he had all these excess toxins floating through his body that he was able to keep up with and get out, but he was still seeing a lot of that. And this benzene here, he can't get out at all. So that's just accumulating on the inside of him, and again, potentially creating a carcinogenic type of circumstance. So we actually follow this up with some of the genetics for his detoxification enzymes, and sure enough, he had some polymorphisms involving these cytochrome P450 detoxification enzymes. And this one right here is specific for the aromatic hydrocarbons, which benzene happens to be one of. So he can't process that very well because of this genetic predisposition. Now furthermore, remember his profile, how it showed that he was really seemingly having a hard time getting to that reduced glutathione, and all the things moving away from it were going into excess, all the things moving towards it were getting used up like crazy. sure enough, he's got 2 of the 3 main glutathione conjugation genes, one of which was absent altogether, the other one with the homozygous positive polymorphism. So again, even if he was able to get through the P450s, the glutathione would not be able to do that final conjugation step to allow him to get that thing back out of his body. Oh, and then couple this with that superoxide dismutase. This was another thing that Dr. Ron mentioned, but this one's specific to the mitochondria, and again, is that piece that allows you to take superoxide and convert it to hydrogen peroxide. Without that, you start to tweak out the mitochondria and then further give it a little trouble. So again, this is the manganese superoxide dismutase. This is the one that's mitochondrial specific. Interestingly, as we've started to look at these genetic panels in our cancer patients, of the 70 or so that we have now, 67 of them carry this polymorphism, which is pretty phenomenal. So anyway, this, as you do some research, you can see that this SOD2 is recognized as a tumor suppressor, without which you start to get into this uncontrolled replication, and again, the cancer phenotypes that can develop from the mitochondrial shift that you start to see in cancer. So again, the superoxide dismutase is basically the enzyme that allows this arrow to occur. And this is pretty awesome because here's the superoxide. The superoxide dismutase allows you to go to hydrogen peroxide, and then you can continue on your way to this water domain, which again allows you to regain all of your organization to keep yourself put together. If you've seen any of Martin Paul's work, he's published a few places. I think he's actually published in the Journal of Orthomolecular Medicine on this. But if this is blocked off here, your body starts to go down this no-oh-no cycle, and this is a common phenomenon followed in cancer patients as well. It's a pro-inflammatory feed-forward cycle that's just hard to break once you start to go down that pathway. So anyway, it's awesome here in the sense that if this is the enzyme that's knocked out, it's no wonder that IV vitamin C does some special things because it picks up right here where you left off. So anyway, it starts to reestablish the correct flow, which potentially got disrupted. In essence, getting back to this organization so you can tighten up the person's space and help them contain their tumors a little bit better. So here we enter the vitamin C in cancer story. Again, there are some early studies, the continued work, the anecdotal reports, great public interest, looking into safety, efficacy, and now the mechanism of action. So again, going back to Linus Pauling, he was the one that coined this orthomolecular medicine megavitamin therapy and showed that by giving 10 grams of vitamin C, you actually did get an anti-cancer effect. So there are some follow-up studies, again, through the Mayo Clinic. They also used 10 grams of vitamin C daily, and they showed no anti-cancer effect. So there was quite a discrepancy, but the Mayo Clinic has a lot of clout, and it basically closed the story. It says, yeah, vitamin C doesn't help at all. So that was the end of it. So quite a ways later, I mean, it was a number of years, people started to look at this again and started to realize that, yeah, this Cameron and Pauling study was IV followed by oral, whereas the Mayo Clinic was just the oral. So this is where Dr. Riordan comes in, because he was the one that actually, I think, played an integral role in keeping this research alive. And through the center here, continue to use the IV vitamin C in clinical use and looking at the basic science. So he actually has some articles revealing the case reports and so forth, and this continued to drive interest. The pharmacokinetics continue to be elucidated. This is what happens when you orally take vitamin C. It just flattens out. After only about 1,000 milligrams, you really can't get any more. Now this can go up and down pretty quick, so there may be times when you're under a lot of stress and need to keep filling that in. But the point is, you can saturate yourself so you really can't increase your blood levels after you reach that threshold. So now if you go IV, you can bypass that tight control through the digestive tract, and you can just go as high as you want. So here we have this line down here shows the oral, where you don't even get off the ground at all. You still stay in the micromolar concentration range. But as soon as you start to go IV, very quickly you just magnitudes increased in the concentration in the bloodstream. And now we're getting into millimolar ranges, which is magnitudes against more concentrated. So this is where it gets a little squirrely because, again, Albert St. George first discovered vitamin C because it helped to facilitate the charge transfer to allow oxidative respiration to occur. So now we're getting super physiological levels of this ascorbic acid, and sure enough, it starts to steal the electron energy off of these metals that can oscillate between the 2+ and the 3+ state. So again, stealing the electron off, converting it to a usable form by way of this Fenton chemistry to create the hydrogen peroxide. In the bloodstream, it's metabolized very quickly, but in the extracellular space, you get prolonged flooding of hydrogen peroxide back into the extracellular space and in those areas where the tumors are found. So here again, you just see this picture of this reaction happening. It's in the extracellular space. You get that flooding over of the tumor. And again, trying to get the reactive oxygen species in there that the mitochondrial shift has made impossible for the tumor to acquire. And so these are just some of the papers that support this backdrop, with the hydrogen peroxide being the agent that does the work. And actually that, yes, you can use vitamin C as a prodrug to deliver hydrogen peroxide to the tissues. So this started to be looked at a bunch of cell lines. These are some normal cell lines, none of which were killed by the pharmacologic activity of vitamin C. But now we see a bunch of cell lines that are the cancer cell lines, and they just can't survive at all under the stress of the hydrogen peroxide that's induced by the pharmacologic vitamin C. Now, not all the tumor cells are killed. There are some that are still resistant, but a lot of them do. So again, it's very plausible that this would be a nice addition to anybody's anti-cancer program. And so actually we followed this up by injecting some of the mice with pancreatic tumors, and we just saw how the tumor growth changed if you use the ascorbate in their routines. So here with saline, you just see the tumors continue to grow at a pretty solid state, or a pretty steady rate. And then if you add the IV vitamin C, the tumors grow at a much slower rate. And then as we just went into more ongoing research, we started to look at how you could combine the different chemotherapies with the IV vitamin C to see what kind of effect you would have. Now, these tumors are pretty responsive to the chemo. This blue mark here is the gemcitabine. This one's the IV vitamin C. The IV vitamin C still outperformed the gemcitabine, but when you combine them together, it actually improved the effect of either one by itself. Now, as you go through, these are more and more chemo-resistant tumors. Now, this one's very chemo-resistant, so all the tumor cells survive despite huge doses of gemcitabine. Again, with a little IV vitamin C, the tumor cells couldn't survive, but if you combined the gemcitabine with the IV vitamin C, then you had hardly anything surviving. So it definitely seemed like there's some synergism between the chemo and the IV vitamin C, and it's this data that probably helps me with the oncologist more than anything, because again, if we know the mechanism of action of the chemo, which has more or less been worked out, otherwise it wouldn't be in as much clinical use, then we can show how our vitamin C will augment their anti-cancer efforts as well. So again, I want to point this out because this shows that, again, the ascorbate and the millimolar concentration cause a lot of cell death. Now, this is important because these bottom two here show the apoptosis. Again, it's a reactive oxygen species mediated reaction where you actually have the energized reactive oxygen species that can induce that apoptosis cascade, which again requires energy. If you run out of energy and ATP, you get into necrosis, which accounts for this little top part. But the vast majority of the cell death is this process called pynknosis. Now, pynknosis is the process of just concentrating the cell, and if you surpass a certain threshold of while you're concentrating, the cell just can't maintain itself, and it'll fall apart and die in the process. Now, another thing here too, again, if you put catalase in there, it blocks the anti-cancer effect. Again, confirming that it is hydrogen peroxide that's doing the activity. Now, this comes up a lot, and I was just talking to Dr. Hyland a moment ago about the catalase, and there's a lot to say that cancer cells don't have a lot of catalase, but I went to actually it was a conference called Reactive Oxygen Species in Health and Medicine. And actually, I found out that catalase endogenously only accounts for about 1% of the metabolism of hydrogen peroxide in vivo typically. And glutathione accounts for a little bit more, maybe 5, maybe up to 10% at the very most. But I don't even think it's that much. I can't remember exactly what the total is. But again, catalase and glutathione account for just a tiny bit. And this whole family you've probably never ever heard of, but this peroxyredoxin group of proteins accounts for more than 2/3 of the metabolism of hydrogen peroxide. So again, it's kind of a black box because I don't know much about these peroxyredoxin proteins. But anyway, they're the way endogenously we deal with our own hydrogen peroxide production. I wanted to bring this up because when I was here 2 years ago when we had the first IV vitamin C symposium, by a show of hands, the question was posed, and those of you that are using IV vitamin C, who adds glutathione to the infusions? And about half the group raised their hand. So knowing that hydrogen peroxide facilitates the cell die-off and the cell death of the cancer cells, if you put glutathione in there, you're just going to metabolize that, that agent. And so it didn't make sense to me and to our group that people would be adding glutathione straight to the IV vitamin C. And sure enough, we were able to show that the cancer die-off was blocked if you added the glutathione, which are these red ones, whereas the vitamin C, you just almost killed it completely. So you block the anti-tumoral effect if you do add that glutathione in there, and I think that's an important point. A piece of this, though, is in the end, glutathione will serve as an antioxidant. Our cancer cells are getting too much oxidative stress, so it can help out. But there's no significant increase in survival over the vitamin C by itself. And most of the time, if you're going to prolong survival, most people want their tumors to shrink at the same time. So really, you can get to the same effect just with the vitamin C and not adding any glutathione in whatsoever. So then, again, it seems like there's this two sides of the equation. On one side, it seems like the hydrogen peroxide, as one of these reactive oxygen species, is able to do some work that maybe is unique only to this reactive oxygen species. Just like this one may be able to perform a little work in its form, this one can perform a little work in its form. And these are probably specific to some of the environmental things that we get into the mix of ourselves. And so again, we've got to have a way to meet and metabolize those things and chew them up. Again, these reactive oxygen species are what get pulled into lysosomes. Our immune system can engulf the bacteria and just eat them up because, again, these are how we can neutralize those environmental inputs. And then on the other side of the equation, not only are you metabolizing something with the power that these carry, but you're able to ultimately reorganize the structure and, again, bring some organization back to that tumor. So these are some of the mechanisms we're looking at. This pathway is talking about the direct damage that you're inducing or that metabolism piece. And then again, the other side is the reorganization of the extracellular space and those connective tissues that can help contain the tumors. So again, coming back to these epithelial to mesenchymal progression pieces, we looked at these different markers just to see kind of what was happening. So this is, again, with the pancreatic cancer tumors, but these are some epithelial markers showing that you do have that organization. And sure enough, with the vitamin C, oh, this one here, you can see how it's just upregulated like crazy with the vitamin C, suggesting that you're maintaining it in that organized way that's like this kind, not like this. And actually, this other one, this E-cadherin up here, when you broke it down into the different subunits, this 33 kilodalton one actually decreased, and this is an apoptosis inhibitor. So if you block that, you can create the apoptosis a lot better. And again, this is in response to the ascorbic acid doing that. Okay. So this was just a cell histological rendition of that. This Matrigel is like a membrane that you put into the culture of the cells. So this one had no membrane and no vitamin C, and you can see how well the tumor cells grew. This one has no membrane, but you do put the ascorbic acid in, and sure enough, the cells can't grow as well. There's not nearly as many there as compared to there. And then these ones do show the membrane, and without the ascorbic acid, still a lot of the cells were able to get through the membrane and metastasize, so to speak. And then this one has the ascorbic acid with the membrane, and sure enough, you couldn't get as much metastasis through that membrane. And this is another way to look at that. We were talking about how vitamin C can help strengthen the collagen. And this blue stain here, you can kind of see it in the background, is that collagen. And this doesn't show up too well, but you can see a significant increase in the collagen formation as you use the vitamin C as compared to the controls. The gemcitabine does it pretty well here too, but the ascorbic acid plus the gemcitabine does the most. So it's really pulling together that connective tissue and enabling you to reorganize that space surrounding the tumor, again, creating a more unified and organized soil, so to speak, as we mentioned, it referred to in the previous lecture. So then we come into the ovarian cancer, because again, we need the trials, so that's a lot of fun stuff, but it really doesn't matter to the oncologist until we start to get into phase 3 trials, which are starting to get into the efficacy trials. So this was just starting to introduce us to the ovarian cancer. Again, it's the leading cause of death from all gynecological malignancies. Fifth leading cause of cancer-related death among women, yet accounts for only 3% of cancers in women. So again, it's a very lethal cancer. If you do catch it, it only accounts for a small amount of them, but usually the people will succumb once they do catch it or develop it. So again, this was a phase 1, 2A pilot trial, really just looking at the safety and some of the pharmacokinetics and so forth. But we really only chose the people with the worst of the worst cancer conditions, stage 3 or 4. They had surgery where they tried to debulk the tumors as much as possible, and then they were chemo naive and radiation naive at the baseline. And they had to be pretty high function, ambulatory status with performance status 0 to 2, which is, again, the higher. They can walk around in the community, you know, they're not bedridden and stuff like that. And they had to have adequate renal, hepatic, and hematologic function. Now, we excluded some people. People that couldn't, for one reason or another, receive the first-line chemotherapy were excluded. If they had the kidney stones, again, there was some discussion about the development of kidney stones. It's more of a theoretical problem, and again, we hardly ever see that. We did have one gentleman develop kidney stones, but it's just not a problem we see very often. And if they use tobacco products, the IV vitamin C usually couldn't overcome the oxidative stress that the tobacco induced. So when we try to get the post-infusion blood levels up, if they were smoking, we just found that they weren't usually able to get their blood levels up to our targets. So basically, we ended up with 27 people. We randomly assigned them to either the control arm or the treatment arm. The treatment arm included adding vitamin C to the chemo consisting of paclitaxel and carboplatin. So we had people just receiving chemo, and we had people receiving the IV vitamin C in addition to the chemo. So actually, the infusions were only twice a week, and they went on for a full year, and the chemo was only given for the first 6 months of that year. So basically, our primary objective was just to determine the safety of the high-dose vitamin C when combined with the first-line chemotherapy. And actually, we used the National Cancer Institute's common terminology criteria for adverse events. But we also had the secondary objective just to see if there was a trend of benefit by adding the vitamin C, if they would improve survival. So basically, the results were adverse event reporting occurred during the administration of the chemotherapy stage of the trial only, and there were no adverse events reported for those people that were just receiving the IV vitamin C in that second half of the year. But all the adverse events, again, were reported during the chemotherapy phase. And actually, the people that just were getting chemotherapy reported adverse events at 5 times the rate of those that were receiving the vitamin C alongside. Actually, when we looked at the survival curve, there was a trend to benefit in the people that were getting IV vitamin C, but the changes weren't significant. Maybe if the trials were longer or if we had more people, that would have become significant. It was still nice to see the trend, but again, our numbers weren't big enough to provide the statistical significance to show that was real. Anyway, this is just a graphical rendition. The blue is just the chemo group. The red is the chemo plus the vitamin C. These are all the toxicity complaints per visit. And you can see the grade 1 is the lower grade, and the grade 4 are the ones where you have to be hospitalized and stuff like this. But you can see that consistently across all categories, the people just receiving the chemotherapy had a lot worse time of it. And again, knowing that the vitamin C did not interfere with the anti-cancer effect, that's pretty profound in the sense that it's safer, more tolerable, and had just as good outcomes, if not perhaps better. So again, these were some of the specific toxicity complaints. Again, these were just organized by the criteria, again, the National Cancer Center puts out, or how they organize the terms. But again, the blue one being the just the chemotherapy, and they pretty much had more complaints than the IV vitamin C addition. So basically, in conclusion, the intravenous ascorbate is recognized as a pro-oxidative therapy with wide clinical use and remarkable safety record, together with the suggested trend to benefit when combined with traditional cancer care, does warrant larger prospective studies in regards to its role in cancer treatment. This is our picture of our clinic. I don't know if you can see that too well. This is our infusion clinic. We've got basically 10 chairs, some isolation rooms at the end, and that's kind of where it all happens at KU. And this is just part of our team, our basic science group, KCHEN, and then the clinic over here. So anyway, thank you.
Have you carried on to see if there's, with the vitamin C, it actually has helped survival? Or
yeah,
did it
you know, I wish we had, but we really didn't. So
how long
basically, we just had the 1 year-long trial, and that's really all we have the data for. We have followed along with some of the patients, but not in an organized way.
Any benefits with vitamin C?
Well, we're working with a lot of people that are between 5 and 10 years out from their diagnosis, so that's pretty exciting.
Dr. Gus Kutsan is from Texas. How does the change of the architecture of the tissue affect the cancer itself?
Well, one of the things we've seen is that when we follow along the PET scan, you know, again, the PET scan is following along the glucose being absorbed by the tumor. And again, if you're in this inefficient anaerobic metabolism path or pattern, you're going to start pulling in the glucose like crazy. It's going to take a lot more to get you to the energetic needs that you are looking for. As we give the IV vitamin C, we've seen that signal slowly burn out so that some of them don't even have a signal at all anymore. They've got tumors in there still, but they don't shine on the PET scan. Another thing is, you know, we talked about this deficit. So if you have this huge pool you're trying to fill up, you start flooding in the vitamin C, you get the hydrogen peroxide, it starts to reorganize that space. So you've got this unorganized array of all the water, and then now all of a sudden it can soak back up into an organized fashion. Just like if you're stacking a bunch of cups together, you can pack them into a small space, where if you just threw them all on here, all disorganized, I could maybe only put a little pile up here, you know. But anyway, we've worked with people where at first they might require 100 to 125 grams to maintain the blood levels that we're looking for. And then a couple months later, they may only need 100 grams. And you can just see the steady decline where after maybe 6 months, they only need 50,000 in infusion to get to the blood levels. So clearly, you're filling in some sort of leak and helping them to reorganize that. And then they just can't fit any more in there because it's getting filled up again. And then their redox potential goes up. Again, they just have stability, color in their face, just fun stuff like that.
One more question on pycnosis and necrosis. What happens to the architecture?
Okay, so the necrosis, I think it just starts to fall apart just in a totally unorganized pattern. Now, I've seen some of the ways they look at the difference between that, and we've actually got a bunch of stuff now on autophagy. I don't know if you're familiar with this, but this kind of process by which the cell will kind of eat itself. And again, you're just trying to take those structural elements and reorganize them into an optimal organization pattern so that then you can keep your wherewithal. So there's a lot of different ways your body can kind of concentrate itself, so to speak, and that's been looked at from a number of different groups and different avenues, not just IV vitamin C, but how you can just grease up the mitochondria energetics. Now the pink gnosis, again, there's a very, there's well-known characterization of each of those pathways, and I can't go into all the details, but our basic science group, I mean, that's what they do, and they just try to follow the standards that have been outlined for these different avenues of cell death, and they try to characterize what seems to be happening.